Welcome to the Deep Dive. Today, we're really going to get into something fundamental, I think, for all of us. How hospitals are, well, supposed to care for you. We're talking about patient-centered care, but not just, the idea.
Right.
We're looking at the actual rules, the expectations. Our mission today is to unpack the GAHAR Handbook. That's the General Authority for Healthcare Accreditation and Regulation, specifically their Hospital Accreditation Standards.
It's a pretty detailed guide.
It really is. We want to translate what these standards actually demand from hospitals and, maybe more importantly, how that changes things for you, whether you're a patient or visiting family. This isn't just about ticking boxes.
No, definitely not.
It's meant to be a whole shift in thinking, putting you first.
Exactly. And these GHAR standards, they're meticulously put together. They really aim to make sure that, every part of the care process, every interaction, every decision, it all genuinely centers on the individual patient, their needs, their preferences.
It's a big shift from how things maybe used to be.
A profound systemic shift. Absolutely.
Okay, so let's unpack that. This foundational idea, GHR calls it patient-centeredness, PCC.01, I think.
That's the one, PCC.01.
Right, and the idea isn't just like being nice to patients, it's structural. It's about dismantling that older sort of provider knows best culture and rebuilding the whole experience around the patient, which for hospitals must mean rethinking, well, almost everything. Staff training, how rooms are set up.
Oh, absolutely. And what's really striking is the sheer effort this requires. It's not just a memo saying be patient-centered.
Right.
It demands really careful planning. Being flexible during implementation, adapting to what actually happens on the ground.
Yeah.
And then constant, rigorous monitoring. It's not a one-off.
It's a commitment.
Living, breathing commitment, yes.
And the how they make this happen. This part surprised me a bit. The handbook says hospitals have to set up a specific committee, a multidisciplinary one.
Yes, that's key. Multidisciplinary.
To plan and oversee this whole patient-centered culture. But here's the kicker, the detail I found interesting. Active members must include patients and family members.
Right. Actual patients.
Yeah, like maybe someone who's there often or a long-term patient, sitting at the table with junior staff, managers, clinical folks, non-clinical, everyone.
That's quite a powerful requirement, isn't it? But I suppose the question is, how do you make sure those voices, the patient and family voices, aren't just, well, token gestures?
Right, exactly.
Like, how do they genuinely influence things, address the real problems?
Well, that seems to be the point. The standards detail what this committee does. They have to create the vision, the plan, then communicate it, educate staff so they actually get it. And crucially, they need to find the roadblocks, the resistance, the old habits, and actively work to remove them. It's all geared towards empowering patients, to make informed choices. The committee clears the path.
So it's about embedding it systemically.
Seems like it. So knowing hospitals are supposed to be this committed, what does that mean for you when you're actually in the hospital? GAHAR is very clear on this, too. It's about balance.
The two-way street idea.
Exactly. Your rights, which are undeniable, but also your responsibilities, your part in it.
Which patients sometimes forget, perhaps.
Maybe. So let's look at the patient and family rights first. PCC.02. The standards stress how crucial it is that you understand your rights and can actually use them. And hospitals have to help you understand.
And the duty to inform.
Right. And these rights aren't just made up. They come from laws, regulations, ethics codes. Some specifics they list. Things like your right to access care in the first place, knowing who's treating you, the names.
The basic, but important.
Definitely. Getting care that respects your personal values, your beliefs, being part of the decisions. The right to say no, to refuse or stop care. Security, privacy, confidentiality, dignity. Those are big ones. Having your pain assessed and treated. And this one feels really key. Making a complaint or suggestion without worrying about backlash.
That fear of retribution is a real barrier sometimes.
Totally. And also knowing the price of services and seeking a second opinion, inside or outside the hospital.
That price transparency one, that's a tough one for hospitals, practically speaking.
You think so?
Well, yeah. Stating the right is one thing. But actually providing, immediate, accurate cost estimates for all sorts of procedures, different patient situations, it's complex.
I can see that.
Many hospitals are still figuring out the best way to make that truly clear and usable for patients, even with the standard in place. Making sure it works involves, clear internal policies, lots of staff training, putting up posters, but how you actually get that information is crucial.
Makes sense. Okay, so that's rates. But the flip side, as we said, is patient and family responsibilities. PCC.03, hospitals have to make sure you can take these on and help if you don't understand. And like the rights, these need to be visible, known.
So what kind of responsibilities are we talking about?
Things like giving clear, accurate info about your health history. That's vital. Following hospital rules and procedures.
Right, the practical scope.
Paying your bills, basically fulfilling financial obligations. Showing respect to other staff, other patients. And importantly, following the treatment plan that you've hopefully agreed to.
And if we connect this back, that bigger picture, keeping this patient-centered culture alive really depends on monitoring both sides, right? Rights and responsibilities.
Why so?
Well, the standards require that everyone, staff, patients, families, feels empowered to report violations or problems on either side.
Ah, okay.
That feedback loop is just essential for hospitals to spot issues and actually improve things, keep everyone accountable. Without that reporting, the system just stays static.
Got it. Okay, so moving on. How do hospitals make sure you're actually informed, that you're involved in the decisions? It starts right at the beginning with admission consent. PCC.04.
Right, the initial paperwork.
But it's more than just signing. It's supposed to be about you understanding and agreeing to the whole hospital stay, potential costs, risks, what's expected of you.
And crucially,
in a language you understand. Yes, that's explicitly stated.
Which brings up a really important practical point for hospitals, doesn't it? What do you do in those tricky, maybe urgent situations where the patient can't give consent? Maybe they're unconscious or confused, and there's no legal representative right there.
Yeah, what happens then?
The GAHAR standards say hospitals must have established legal and ethical procedures ready for exactly that. To protect the patient's best interests, it can be incredibly tough to navigate those moments correctly.
A crucial safety net then. Okay, so after admission, we get to informed consent. PCC.08. This feels like a cornerstone.
It absolutely is. A pillar of patient involvement.
It's your permission, right, before they do any intervention or even share your info. GAHAR lists specifics needing consent. Surgery, invasive procedures, anesthesia, blood stuff, using it or donating it.
High-risk treatments, too.
Yeah, things like ECT, radiation, chemo, participating in research, obviously, and even like taking photos or videos for hospital use.
Right.
And for it to be truly informed, they have to tell you the chances of success, the risks if you don't do it, the benefits, and any alternatives.
All the critical information for a real choice.
But what I found really interesting is PCC.09, informed consent validity. They actually define when your consent becomes, well, invalid, stops counting.
Ah, yes, that's important. It's not indefinite.
Exactly. It highlights how dynamic things are in a hospital. Your consent might not be valid anymore if your health changes significantly, or the care plan changes, or new info comes up with different risks.
Or even if time passes,
Yeah.
right? Especially for complex things.
Yes, a certain time limit, or if your mental state changes, or even if a different doctor ends up doing the procedure than the one you consented with.
That last one is often overlooked.
Hospitals have to define these situations and have a process for getting new consent, making sure you're always deciding based on the latest picture.
It's really about making sure consent isn't just a tick box exercise at the start.
Right.
It needs to stay current, reflecting your understanding and willingness as things evolve. It stops old consent becoming, meaningless or even harmful later on.
Absolutely. And building on that, there's informed refusal. PCC.10. You have the absolute right to say no or to stop care.
Even if it's against medical advice.
Yes, the whole AMA, DAMA, ALEMA thing, against medical advice, discharge AMA, leaving AMA. If your choice goes against what's normally recommended, the hospital must educate you on the risks and benefits of your decision.
Not pressure you, but inform you.
Exactly. Their policy has to spell out how they tell you about your condition, the consequences of refusing, how they record it all properly, and what alternatives they can offer.
This is so vital for genuine patient empowerment. Letting people make choices, even difficult ones, as long as they understand the implications.
Yeah.
It's not about forcing compliance. And hospitals are meant to track this data too. Why are patients refusing? Is there something we can learn, maybe improve our communication or offer different options?
That makes sense. Okay. Beyond consent and refusal, GAHAR puts a huge focus on just basic communication and education. PCC 5, 6, and 7 cover this.
Communication is everything.
PCC.05 says you and your family are actively encouraged to ask questions. All the time. Hospitals need systems for this face-to-face, phone, secure messaging.
With timely responses.
Yes, like within 24 hours for non-urgent stuff. The source even mentions specific tools hospitals might use, like 5 moments of medication safety campaigns or ask me if I washed my hands.
Practical prompts.
Yeah, ways to get you comfortable speaking up, asking those questions about your own safety.
Encouraging that interaction.
Then PCC.06 is about health education materials. This is the broader stuff. Videos in waiting rooms, social media, brochures, pamphlets, maybe even text messages.
Mass communication.
Right, on topics like quitting smoking, managing stress, diet, exercise. But it can't just be generic stuff. It has to be suitable for the patients considering their needs, education level, language, culture, and easy to find.
Accessible and appropriate.
And finally, PCC.07 ensures patient and family education is personally provided. This means tailored education about your diagnosis, your care plan, what outcomes to expect, what the alternatives are, and those critical discharge instructions.
And it's not just one person's job.
No, it's multidisciplinary. Everyone involved has a role, and it all has to be documented, including confirmation that you actually understood it.
Closing that loop, making sure the information landed.
Exactly. Okay, let's shift gears a bit. Beyond the medical stuff, what about just comfort, dignity, the overall experience? GAHAR covers this too.
The holistic side of care.
Yes. PCC.11 emphasizes physical comfort. Hospitals need to think about the design rooms, waiting areas, clinics, making them comfortable. And they quote this stat. Over 600 studies have linked the hospital environment to patient satisfaction, stress, health outcomes, and overall healthcare quality.
Wow, 600 studies. That's significant.
It really is. So think about your last hospital visit. Was it noisy, sterile, or did it feel like a place designed for healing? GAHR says hospitals need to manage things like noise levels.
Oh, the constant beeping.
Right. It's not just annoying. It actually gets in the way of recovery, increases stress. They also mention pain management, cleanliness, and layouts that make communication easier.
Practical things, too.
Yeah, like healthy food being available 24/7, maybe from a cafeteria or vending machines. And making waiting areas better, tackling uncomfortable seats, lack of things to do, overcrowding.
Addressing those common frustrations.
Yeah. Then there's PCC.12, emotional, religious, and spiritual needs. Care has to be sensitive here.
Cultural competence comes in.
Exactly. Staff need training in that. Hospitals should offer access to support like counseling or religious leaders if needed. And even routine things, cleaning schedules, food service times should try to adapt to patient preferences and traditions where possible.
Respecting the whole person.
And PCC 13 underlines dignity, privacy, and confidentiality. You have the right to be treated respectfully, always. Privacy is crucial during interviews, exams, procedures, even being moved around.
Privacy from whom?
From other staff, other patients, and even, it says, from family members if you want that privacy.
The patient's choice.
Yes. And of course, keeping all your information confidential.
Standard, but essential.
Finally, a really practical one. Patients' belongings, PCC 14. Hospitals need a clear policy on their responsibility for your stuff, clothes, glasses, dentures, but also valuables.
Jewelry, electronics, cash.
Right. The policy needs to cover how they accept custody, tell you about it, who's responsible, how items are recorded and protected, and what happens with lost and found.
Reducing that extra layer of worry.
Exactly. Okay, so to wrap up, how does your voice actually lead to improvement? How do hospitals listen? PCC 15 is about patient and family feedback.
Gathering that input.
Hospitals must measure feedback concerns, compliments, complaints, surveys to improve both clinical stuff and non-clinical services. They can use phone surveys, written ones, focus groups, interviews.
Written surveys often being cost-effective.
Apparently so. And they need feedback from all types of patients, inpatients, outpatients, emergency.
And it's important here, I think, to distinguish, are they measuring patient experience? Like, did the thing that was supposed to happen actually happen? Or patient satisfaction where your expectations met? They're related, but different.
That's a good point.
And the GAHR standards are really clear. Just collecting the data, that's not enough. Hospitals have to analyze it, interpret it, and crucially, use it to make real changes.
Okay.
Implement improvements. Otherwise, it's just data sitting there.
Actionable insights.
Exactly. Without action, feedback is just noise.
Okay, and finally, PCC 16, complaints and suggestions. Hospitals need a defined process for handling these, whether you raise them verbally or in writing.
Clear channels.
Yes. The policy has to lay out the communication channels, how things are tracked, who's responsible for responding, and this is key. the timeframes for getting back to you with feedback or a resolution.
This is absolutely non-negotiable for accountability.
Seems like it.
Complaints have to be investigated properly, analyzed to figure out the root cause, and resolved within those set timelines. And critically, you, the patient, must get feedback on what happened within those approved times.
So your voice actually drives change.
It ensures your voice contributes to real systemic improvement, not just disappears into, well, a suggestion box.
Right. So pulling all this together, what does it really mean for you, the listener, interacting with healthcare?
Mm-hmm.
The big takeaways for me are, well, how comprehensive this is. Patient-centered care by these GAHAR standards isn't fluffy. It's a detailed, multidisciplinary system.
Covering so many aspects.
Yeah, your rights and responsibilities are clearly laid out. Informed decision-making is central. There's a focus on holistic comfort and dignity. And these feedback loops are built in for continuous improvement.
It really provides a powerful framework, doesn't it, for hospitals to genuinely prioritize the individual. It shifts the whole dynamic. You're not just passively receiving care.
You're meant to be an active participant.
An active, empowered participant in your own health journey. It fundamentally changes that relationship.
So maybe the final thought for everyone listening is, how can knowing about these standards actually empower you when you or a loved one are in the hospital next time? How can this knowledge help you advocate effectively, make sure your voice is heard, your needs met? What specific question might you ask now, knowing what true patient-centered care is supposed to look like according to these very detailed standards?